Hello, everyone. Thank you for joining our webinar tonight. I'm Joanna. I'm a member of the SIR Resident Fellow section. If you haven't had the chance yet, please do check out our website at rfs.sirweb.org. On our website, you will find a schedule of our upcoming webinars and very much more. So without further ado, I'm going to pass it off to Vatsal. Vatsal is a member of our Vascular Diseases Service line, and he will be introducing our speaker for tonight.
Hello, everybody. My name is Vatsal Patel. I'm a PGY2 at Yale Human Hospital. Today, our speaker will be Dr. Dennis Moledina, who is a very highly regarded Nephrology Fellow at the Yale Human Hospital. He's also a research fellow at Yale Program of Applied Translational Research. And today he'll be delivering a webinar on treatment options for venous thromboembolism in patients on hemodialysis. The stage is yours, Dr. Moledina.
Thank you, Vatsal. My name is Dennis Moledina. As Vatsal said, I'm one of the clinical fellows in nephrology at Yale Human Hospital. So today's talk is treatment options for venous thromboembolism in patients on hemodialysis. This is a talk that was originally intended for nephrologists in practice. I modified it a little bit to suit our needs today. So here we go. So our learning objectives for today, it'll be a case-based presentation. Case 1 will try to answer the following 2 questions. Question 1, can low molecular weight heparins be used to treat venous thromboembolism in patients on hemodialysis? And question 2, does therapeutic monitoring exist for low molecular weight heparins? The second case will answer the following 2 questions. What are the options for treatment of venous thromboembolism in end-stage renal disease? And finally, can any of the newer anticoagulants be used in chronic kidney disease or end-stage renal disease? So just before we get started, what we will not talk about today is use of low molecular weight heparins for DVT prophylaxis. And we will not go into the indications for anticoagulation and atrial fibrillation. That's a murky topic for another day. So this is something I added for our talk today. This is something that would not come as a surprise to any nephrologist, but for the rest of medicine, the challenges we face as nephrologists are quite unknown. So first of all, there is lack of evidence specific to our population, and I'll dedicate a slide to that. And secondly, the drug absorption, metabolism, and elimination are quite inconsistent in our chronic kidney disease or end-stage renal disease patients. So this first study that I'm presenting is from Steve Poca from Yale. He talks about the underrepresentation of renal disease in randomized controlled trials. He looked at 153 randomized controlled trials between 1985 and 2005. And what he found was quite surprising. He found that 56% of the trials clearly excluded renal patients. Only 5% made any mention of renal patients that were included. And only 10% of the trials listed baseline renal function. In fact, renal patients were more likely to be excluded when the trials were multi-center, were from North America, and when they tested anticoagulation, which is our topic today. The second point is the changes that happen to drug handling in chronic kidney disease and end-stage renal disease. The absorption is different because most of these patients are on phosphate binders, which bind a lot of drugs. There's alteration in the first-pass metabolism. There is reduced plasma protein binding, which leads to higher availability of the free drug. There is there's alteration in volume of distribution. There's altered metabolism. The metabolites are not excreted. And finally, the one we think about most commonly is reduced excretion and prolonged half-life. So there's some general principles that we as nephrologists follow while we prescribe drugs in our ESRD and CKD population. We admit that it's difficult to predict the clinical consequences of uremia-related alterations in individual patients. Most of our dialytic modalities will remove some of the drug. And where therapeutic monitoring exists, we recommend using that. So for example, we try to measure drug levels in drugs such as phenytoin, Or we try to monitor the effect of a drug, such as measuring the blood pressure, measuring PTT, or measuring INR. We always try to measure the free drug level when available. And of course, you can only use therapeutic monitoring when efficacy and toxicity levels are known for a particular drug, which is quite important in our topic today. So our first case, this is a patient I saw at Yale New Haven Hospital, a 63-year-old man with end-stage renal disease on hemodialysis, had a recent deep venous thrombosis, who is currently on warfarin, now needs vascular surgery. He has switched from warfarin to enoxaparin with therapeutic monitoring of anti-10A levels by his outpatient healthcare provider. Now he gets admitted to the hospital, and the nephrology service, which is me, is asked to comment if his anti-10A levels are therapeutic. So the questions that I had: can low molecular weight heparins be used to treat venous thromboembolism in hemodialysis patients? And secondly, does therapeutic monitoring exist for low molecular weight heparin, and is it valid? So first of all, how big is the problem? Going into the epidemiology of deep venous thrombosis and pulmonary embolism in chronic kidney disease and end-stage renal disease. Studies before 2000 had described deep venous thrombosis as vanishingly rare and exceedingly uncommon in hemodialysis population due to acquired platelet dysfunction. This clearly is not true from our experience. The current magnitude of the problem: the annual incidence of pulmonary embolism in the general population is about 66 per 100,000. It increases to 204 per 100,000 in chronic kidney disease, and it's about 527 per 100,000 in end-stage renal disease. The mortality is higher and the length of stay longer in end-stage renal disease and chronic kidney disease patients as compared to normal kidney function. So we cannot start talking about anticoagulation without first talking about J. McLean. J. McLean is credited with the discovery of heparin in 1916 as a second-year medical student at Hopkins. He was working with Dr. Howell, and he accidentally discovered heparin, which he thought was antithrombin. Dr. Howell, of course, didn't believe his findings, but J. McLean persisted, and that eventually led to the discovery of heparin. So what kind of heparins are available for our use today? Heparins can broadly be divided into unfractionated, low molecular weight, or synthetic. Unfractionated heparin, or UFH, as I'll refer to it during the talk, is a glycosaminoglycan produced from granules of the mast cells. It's commercially prepared from pig intestinal mucosa, which is rich in mast cells. Its size varies from 5,000 to 30,000 Daltons and has about 40 saccharide units. Heparin derivatives are called low molecular weight heparins. The commonly available low molecular weight heparins are enoxaparin, dalteparin, and tinzaparin, and they all vary in their sizes. The one synthetic heparin that's available is called fondaparinux or Rextra, which is the smallest molecule amongst all the heparins that are available. Just two quick slides on the mechanism of action of the heparins. This is the interaction between antithrombin 3 and clotting enzymes in the absence of heparin, which is to say there is no interaction. In presence of heparin, antithrombin 3 is able to bind to various clotting enzymes and leads to anticoagulation. The binding of antithrombin 3 to different coagulation enzymes depends on the size of the heparins. Larger heparins are able to bind to both antithrombin 3 and both anti-10A and thrombin, whereas smaller heparins only bind to anti-10A. And thus the ratio of antithrombin to anti-10A activity varies depending on the size of heparin. For example, unfractionated heparin has a very high antithrombin activity and thus can be monitored using PTT, whereas fondaparinux, smallest of the heparins, cannot bind to thrombin at all and thus cannot be measured using PTT. So why do we need low molecular weight heparins or synthetic heparins as compared to unfractionated heparin? Well, they have more reliable pharmacokinetics. In fact, none of the trials that use low molecular weight heparins or fondaparinux used any monitoring at all. There's less osteoblast binding and thus less osteoporosis. And there is decreased binding to platelets, thus there is a lower incidence of heparin-induced thrombocytopenia. the disadvantages become prominent, particularly in our population, which is chronic kidney disease or end-stage renal disease, because there is really no way to monitor the low molecular weight heparins. In fact, their binding to thrombin, as I mentioned, is unreliable, and you cannot use PTD at all. The elimination is also different between the unfractionated heparin and low molecular weight heparins. Unfractionated heparin is predominantly eliminated by metabolism in the reticuloendothelial system, and there is no role of the kidneys in their elimination, at least at the therapeutic level. The low molecular weight heparins or fondaparinux is predominantly renally cleared. In fact, fondaparinux, which is the smallest of the heparins, is excreted exclusively by the kidneys. This next study beautifully demonstrates this. This study took, and this is somewhat of an old study, but it very intelligently describes what I'm trying to say. It took 6 healthy volunteers and 5 patients with chronic renal insufficiency, and they were given unfractionated heparin and low molecular weight heparin. The blue graph shows unfractionated heparin, and it shows that the elimination of unfractionated heparin is similar in individuals with chronic renal insufficiency as well as healthy individuals. Whereas low molecular weight heparin tends to persist much longer in individuals with chronic renal insufficiency as compared to healthy volunteers. Thus, the half-life, as demonstrated by the graph, of low molecular weight heparin is much higher in the individuals with chronic renal insufficiency as compared to controls. The second study demonstrates that low molecular weight heparin, in this case enoxaparin, accumulates in individuals with renal impairment. This study took 12 healthy volunteers and 36 patients with chronic kidney disease and gave them subcutaneous injections of low enox, 40 milligrams for 4 days. The table demonstrates that the half-life of enoxaparin is longer on the first day, but the difference between healthy volunteers and severe renal impairment increases by day 4, thus indicating that low enox accumulates in individuals with chronic renal insufficiency. So what are the problems with this? Well, there is increased bleeding. This meta-analysis from 2006 looked at low molecular weight heparins and bleeding in patients with severe renal insufficiency. They looked at 18 studies for all indications of low molecular weight heparins, which included 12 studies for therapeutic anticoagulation for deep venous thrombosis. The major bleeding episodes were much higher in individuals with chronic kidney disease as compared to individuals with GFR above 30. And this effect was most prominent when therapeutic dose of enoxaparin was used, thus indicating that therapeutic doses of low molecular weight heparins have a much higher rate of bleeding in CKD patients as compared with those who have normal renal function. So it's only natural to look for a therapeutic monitoring parameter for low molecular weight heparins. The next 2 studies that I'll present have looked at factor Xa levels and bleeding in CKD patients. This first study is from hospitalized patients who were started on enoxaparin. Anti-Xa levels were measured in all of them. They included 233 patients. It did include 18 hemodialysis patients and 36 patients with GFR less than 30. There were 10.7% major bleeding episodes in the first 5 days. The anti-Xa levels between bleeders and non-bleeders were the same, 1.13 versus 1.14. The study rightly concluded that there is no association of anti-Xa level with bleeding. The second study was a prospective double-blind trial, which evaluated the risk factors of bleeding on anticoagulation. They took 194 patients and randomized them to receive heparin or low molecular weight heparin, in this case fragment. And they dose adjusted to maintain an anti-Xa level between 0.3 and 0.6 in the high-risk group, which was the ones with renal insufficiency. And this graph shows that the patients bled regardless of the anti-Xa level. The x-axis shows the bleeding episodes, and the y-axis shows the anti-Xa levels. The mean anti-Xa levels on the day of the bleeding were not different between bleeders and non-bleeders. And patients bled irrespective of the anti-Xa level. Based on these studies, ACCP concluded in 2012 that the relevance of anti-factor Xa levels is unclear. Several studies have failed to show a relationship between anti-Xa levels and bleeding. Talking about patients with chronic kidney disease, the evidence-based guidelines stated that the dose adjustment in these studies was either empiric to 0.5 versus the standard 1 milligram per kilogram. There are insufficient data on the venous thromboembolism outcomes. Overall, the evidence is indirect and from studies of low quality and provides no advice on how low molecular weight heparin should be reduced if the decision is to reduce. The College of American Pathologists do, however, make a recommendation about anti-10A monitoring. However, all their evidence is level 3. They recommend that certain clinical settings, including renal failure, the low molecular weight heparin should be monitored in these settings. The monitoring should be 4 hours after the injection, and the target is 0.5 to 1.1 in twice daily dosing. The level 3 recommendations in this case are based on isolated anecdotal studies or the consensus of expert practitioners. So, going back to our original questions, does therapeutic monitoring exist for low molecular weight heparins? Yes, it does exist. The peak anti-10A level is an option for monitoring low molecular weight heparin. However, the evidence supporting its use is weak. The recommended targets, if one does choose to monitor, are 0.5 to 1 for twice daily dosing and 1 to 2 for once daily dosing. As I said before, this evidence is expert opinion and there is no clinical trial to support its use. I would say further research is needed with dose-reduced low molecular weight heparins in chronic kidney disease and ESRD to define therapeutic anti-10A levels before it can be recommended in clinical practice. And question 1, should low molecular weight heparins be used to treat venous thromboembolism in patients on hemodialysis? I would say no. The reasons not to use low molecular weight heparins in ESRD are the renal route of elimination, lack of good monitoring parameter, evidence that chronic kidney disease and ESRD patients bleed more on low molecular weight heparin, and the availability of a good alternative, which is unfractionated heparin. If, however, low molecular weight heparins are used in hemodialysis patients, these should be done with anti-10A level monitoring and with extreme caution. So moving on to case 2. The second case I saw at the West Haven VA, it's a 70-year-old man on hemodialysis, is on chemotherapy for metastatic lung cancer. He's found to have deep venous thrombosis and suspected pulmonary embolism. The physician responsible for him asked the Renal Fellow about options for treatment of DVT and PE in hemodialysis patients other than IV heparin. So the questions I'll try to answer in this case: what are the options for treatment of venous thromboembolism and end-stage renal disease? And can any of the newer anticoagulants be used in the CKD and ESRD patients? So first of all, getting IV unfractionated heparin out of the way. IV UFH is the drug of choice in the treatment of thromboembolism in CKD and ESRD. Why is it the drug of choice? Well, there's years of experience. It has a validated and universally available therapeutic monitoring parameter, which is the PTT. And it is inactivated by the reticuloendothelial system, and there is no renal clearance. However, the IV route of administration does preclude outpatient management, and the dialysis patients often have poor IV access. So can subcutaneous unfractionated heparin be used to treat DVT? Well, this Cochrane database review from 2009 concludes that it can. The objective of this review was to explore the effectiveness and safety of subcutaneous unfractionated heparin for initial treatment of deep venous thrombosis as compared to IV UFH or low molecular weight heparin. It included 15 randomized control trials with over 3,000 participants. The differences in all major outcomes of efficacy, which were recurrent DVT and PE at 3 months, and safety, which included bleeding and death, were non-significant between the different groups. Thus, subcutaneous heparin can be considered non-inferior to IV unfractionated heparin and low molecular heparin for treatment of DVT. The current guidelines from the ACCP from 2012 also include use of subcutaneous heparin, subcutaneous unfractionated heparin for treatment of acute DVT. The dose that they recommend is 333 units per kilogram as a loading dose, followed by 250 units per kilogram every 12 hours. And this can be used in the outpatient setting also. In fact, there is a high concentration heparin available in most pharmacies, which can be used for this purpose. Can subcutaneous heparin be monitored? Yes, a lot of studies actually did the monitoring. PTT measurement is generally not required, but should be performed in end-stage renal disease. Most studies use a mid-interval PTT measurement with a target of 1.5 to 3 times the control, which is 60 to 90 seconds for most labs. So question 3, what are the options for treatment of venous thromboembolism in ESRD? Unfractionated heparin seems to be the most reasonable option for parenteral anticoagulation in ESRD patients. The non-renal route of elimination at therapeutic doses and the valid monitoring option, which is the PTT, make it an attractive option. It can be used in the IV or SC form. PTT monitoring can be used for both of them. And the subcutaneous heparin can be used in the outpatient setting, as has been done by multiple trials. So finally, a word about the newer anticoagulants. Since the early 2000s, multiple newer anticoagulants came into practice. Dabigatran first for venous thromboembolism, followed by its use in pulmonary embolism, Rivaroxaban, and Apixaban. Now, all of you are an educated audience and can probably answer this question as to how many of these studies actually included chronic kidney disease and end-stage renal disease patients, and the answer is none of them. We'll still go ahead and review these drugs, whether or not they can be used in our population. First of all, dabigatran, which is direct thrombin inhibitor, and then there are 3 anti-10A inhibitors, which include Rivaroxaban, XARELTO, Apixaban, Eliquis, and Vitrixaban. So let me start off with Rivaroxaban, which is XARELTO. It's a factor 10A inhibitor. It's actually FDA approved for treatment of DVT and PE in the general population. It does have a high plasma protein binding and thus cannot be dialyzed. Per FDA prescribing information, it should be avoided in patients with creatinine clearance less than 30, which is CKD stage 4 and 5 and end-stage renal disease. In fact, the clinical trials excluded patients with GFR less than 30. Second is Apixaban or Eliquis, also a factor 10A inhibitor. Clinical trials have shown its efficacy in DVT and PE. The trials actually reduced the dose to 2.5 BID for any 2 of the following 3, which included creatinine above 1.5, body weight less than 60, and age above 80. The studies completely excluded patients with GFR less than 25 or creatinine above 2.5. Eliquis also has a high plasma protein binding and thus cannot be dialyzed. However, its renal excretion is only 27%. And if future trials show that it can be used safely in CKD patients, then this is a promising alternative. Finally, Pradaxa or dabigatran is a direct thrombin inhibitor. Clinical trials have shown that it's efficacious in DVT and PE, and it has FDA approval for both these indications. However, this drug is 80% renally excreted and thus accumulates in CKD patients and should not be used. However, in cases of overdose, it can be dialyzed off as it's not plasma protein bound. And finally, this drug, which has not yet been approved for any of the indications, but the reason I'm mentioning it is because it has minimal renal clearance and maybe a bright prospect in the future. It's a 10A inhibitor called Vitrixaban. It had a phase 2 study which included patients with GFR less than 40. It's currently in a phase 3 trial known as APEX, which compares Vitrixaban to Enoxaparin. So this is something to look out for in the future. The same company is also developing a factor 10A decoy, which can be used to treat overdose of any of these medications. It's called Endaxanet alpha, or PRT4445 is a molecule, and it's currently being studied to reverse the effects of Apixaban and Rivaroxaban. Finally, a word about vitamin K antagonists such as Coumadin. According to one estimate, almost 37% of end-stage renal disease patients are on vitamin K antagonist therapies for various indications. Vitamin K antagonists such as Coumadin remain the drug of choice for long-term anticoagulation in end-stage renal disease. They have a valid monitoring parameter, which is the INR. It's easy to reverse in cases of overdose. One can use vitamin K or fresh frozen plasma. The evidence to support their use to prevent access thrombosis, which will be of interest to all of you, is quite weak. In fact, a systematic review found that the bleeding risk is prohibitive when INRs of about 2.5 are targeted. Thus, if decision is made to use Coumadin in cases of access thrombosis, the INR should be maintained between 1.5 and 2.5. And this should be used in very selected patients. Unconventional side effects in ESRD population, which are generally not seen in other people, are accelerated vascular calcification and the rare but dangerous complication of calciphylaxis, which is also known as calcemic uremic arteriopathy. There's about a 10-fold increase in calciphylaxis when patients are started on Coumadin. And the mechanism of this is via inhibition of gamma carboxylation of matrix glycoprotein, or MGP. So with that, I'll conclude. My conclusions are venous thromboembolism occurs frequently in hemodialysis patients. Subcutaneous unfractionated heparin or IV unfractionated heparin remain the best choice for initial anticoagulation to treat venous thromboembolism in hemodialysis patients. Low molecular weight heparin may be used with extreme caution because it's renally cleared. There's evidence that it tends to accumulate in CKD and ESRD, and there is no good way to monitor the therapy. Data is currently lacking to recommend the newer oral anticoagulants in CKD stage 4 and 5 and ESRD patients, but promising therapies may be at the horizon. And with that, I conclude.